I'm surprised he didn't introduce me as a person from another planet, because I think there's a lot of folks in the nation kind of wondering what we're up to in Vermont. So I'm here to talk a little bit about our new health care reform bill, H202, which, as was just mentioned, will be signed into law by the governor next week. We're very excited to have the signing ceremony coming right up. But before I jump into the bill, I want to tell you a little bit about Vermont. We, as many of you may know, are a small state. We have about 620,000 people in Vermont. We also have, our healthcare spending is $5 billion. So for a lot of other states, that's chump change. CMS frequently refers to our Medicaid program as budget dust. So we are small. We also don't have a lot of money. Our median income in Vermont is about $45,000. So we're not a rich state, but we're feisty. We've been doing healthcare reform for a long time. We started healthcare reform in the 1970s. You may have heard of our former Governor Howard Dean. He achieved universal access for kids in Vermont. We currently have 98% of our children insured, and that has been the case since the 90s. And in 2005, 2006, we had a renewed push for healthcare reform, and we passed a bill which established a private health insurance program called Catamount Health, which was also funded with a sliding scale state subsidy for folks under 300% of the federal poverty guidelines. Another thing about Vermont through our various efforts is that we have a very low uninsured rate. We have about 93% of adults insured as well. Another interesting fact is that many of our uninsured are currently eligible for a program, so a state-subsidized program including Catamount Health. About 70% of adults and something like 75% of kids are currently eligible for what we call Dr. Dinosaur, which insures folks kids up to 300% of poverty. So we have current health insurance options for a lot of our uninsured. And our recent, we've been doing some research on our exchange planning grant. Part of that research was looking at our current uninsured, and that study showed that our uninsured population is going to be pretty hard to reach. So this next push is going to be difficult for us moving forward. So Vermont has proceeded on healthcare reform as if it were a three-legged stool. We look for cost, we look for quality, and we look for access, and we do it simultaneously. We weren't particularly one of the states that moved forward with one versus the other. So we've also been working on health information technology for quite some time. We have a program called the Blueprint for Health, which is establishing advanced practice medical care homes in Vermont. That program's that's been rolling out gradually over time. It's going to be statewide by 2013. So we have a little bit farther to go with that. But so why do healthcare reform now? There's federal reform coming. What are we thinking? So our major focus this year started around cost control, because without cost control, healthcare costs will outstrip economic growth. And in a state like Vermont that doesn't have a lot of income, we're always looking for ways to do things better and more cheaply. Our costs are not spread fairly. They fall disproportionately on the private sector, especially on small business. Many of our businesses in Vermont are small businesses. And what we've heard from small business is that they just can't afford to keep paying insurance premium increases for their employees. And many of our small businesses are spending 20-25% of their income on health insurance because they want to offer that to their employees. We do have 20,000 uninsured and underinsured, and we're not getting the best value for our money. So let's turn to H202. There are three components to H202. The first is creating the Green Mountain Care Board. The purpose of the Green Mountain Care Board is to control healthcare cost growth in a new, innovative way. The second part of the bill, and I'll circle back to each of these, is establishing the Vermont Health Benefit Exchange. Our intention is to establish an exchange in 2014, and so we're moving forward with that implementation using a federal implementation grant. And the third part of our plan is to create Green Mountain Care, which is a plan and also establishes a single-payer healthcare system which would come into being when the waivers, the federal waivers from the Affordable Care Act are available. Those are currently available under federal law in 2017, although our congressional delegation has introduced a bill to move that date forward to 2014. And I'll come back to that piece at the end. So let's talk a little bit about the Green Mountain Care Board. It's a 5-member board appointed by the governor with the advice and consent of the Senate. The focus on that board is really to be 5 smart experts. And they're going to look at overseeing payment reform at all levels. It's roughly modeled on the Maryland rate-setting model. If any of you are familiar with what Maryland has done in their hospital system, they have an all-payer rate-setting model where they include Medicare and they establish one rate for hospital services. So they've basically eliminated the cost shift, more or less, in that area for hospital services. We're looking to do that for all areas of care: primary care, specialty care, hospital care. Over time, this is not going to, we're not going to jump in and do it all next year, but we'll start most likely with hospitals where we already have a budget process in place and move from there. It also incorporates the Blueprint for Health, which I just spoke about, and will focus on pursuing and continuing to push patient-centered medical homes. We're looking at overall budgeting with a reasonable growth rate, and eventually moving towards a system that has oversights over the total system budget. But as I said, that'll evolve over time. Why are we focused on payment reform? Fee-for-service does not control costs and actually creates an incentive to generate greater volume of services. And so that's an area that we felt we really needed to tackle first before we moved to a single payer. Our goal when we move to the single payer is to not spend any more money than we're spending now, but increase coverage for everyone. And how do you do that? You have to do that by changing the way you pay so that you're paying for value and not paying for volume. So that's what this board has to figure out how to do. The second major component of our health bill is the health benefit exchange. Again, we're basically looking at the Massachusetts model of an active purchaser where individuals would pay their premiums into the state, and the state would qualify health plans and standardize insurance options so that people could really have apples-to-apples comparisons. One thing that's different about Vermont than Massachusetts is we currently have 3 insurance companies in all of our markets. In our small group and individual market, we have 2 insurance companies. So we don't have a robust competitive system with many insurers. So our exchange is probably going to look quite a bit different than many other states. But we're going for, as was stated earlier, an exchange on steroids, an exchange that really pushes healthcare reform, an exchange that moves us towards single payer by looking at how can we simplify claims processing and administrative simplification short of moving to a single payer, and how do we reduce the complexity in the system. There are some open questions left in our bill because we felt that we needed additional study to really figure out the right option for Vermont, given our very small population and our small market. Will buying in the exchange be voluntary or mandatory? Will the exchange be the whole market? Or will it, like in Massachusetts, be part of the market? What level of employers will we move into the exchange in 2014? Under the federal law, states have a choice. You can define small employer as 50 employees or less, or 100 employees or less. We're going to look at that to see how does that change the pricing? What's going to make the insurance more affordable? And in addition, assuming we have a market outside the exchange, what will that look like? Will it look? There are some changes in the Affordable Care Act that impact on the individual and small group markets, regardless of whether it's exchange related or not. We're trying to analyze that compared to our current market and figure out the best way to move forward given our situation and our main goal, which is to ensure that there are affordable insurance choices for folks immediately in 2014. So moving on to the third part of our bill, which has been getting the most attention, we have established in the bill Green Mountain Care, which is a program where all Vermonters would be eligible for the program for health insurance, or health coverage, I should say, by virtue of their residency. Your insurance, your coverage would no longer be tied to employment. Employers could still choose to maintain private insurance if they wanted to. It would be illegal for us to prohibit that, actually, under ERISA. So employers would still have options to do as they would. But if they chose not to, their employees would still be covered by Green Mountain Care. And in addition, if the employer chose to offer insurance, their employees would still be covered by Green Mountain Care. So if there were benefits the employer did not cover that Green Mountain Care covered, Green Mountain Care would wrap around the employer benefit. The overall budget for the Green Mountain Care and the benefit structures will be approved by the Green Mountain Care Board. We wanted to find a locus of responsibility for both the benefits and the costs in one entity so that they were really looking at the whole picture. One of the dynamics that has happened in Vermont is that you have payers you have our legislature that wants to ensure certain coverage, they'll pass coverage mandates, but they're not paying for those coverage mandates, so that pushes someplace else. So we really felt it was important to tie that all together. And just to sum up, there are still a lot of open questions on what Green Mountain Care will look like. For example, the financing plan we are underway with and will be reported to the legislature in 2013. The reason for the long time frame is because we want to have a really public process. And there's lots of research questions around implementation because it is a tricky thing to do as a state. So thank you very much, and I look forward to speaking with you more as the forum proceeds.